Hello everybody, I'm Dr. Dheera Samdariya and you are watching Urogynecology for Beginners. And I'm here again today with my two fellows, Dr. Suvrati Bansal and Dr. Dheera Samdariya, who are going to present a case in urogynecology, and we are going to discuss the history, examination, investigation and management of that case. So, who is going to present the history part of it?
Ma'am, I'll be beginning with it. She's Mrs. A, 73-year-old lady who came to us with complaints of mass descending per vagina since 40 years. She's para for living. Yes,
So 73 years old.
Yes, ma'am.
Okay.
She came with complaints of mass PV since 40 years. Ma'am, it was gradual in onset and gradually progressive in nature. It was associated with the sensation of a dragging or a pulling sort of sensation. And ma'am, she did not have any urinary complaints, no bowel complaints, and the mass is reducible and it increases on coughing or any straining activities.
Very good. So as we always say that a mass PV is not always a prolapse, but most of the times it is prolapse. So in history, just to re-emphasize, just to revisit the basic concepts, what are the points of Suvrati you will ask in history to confirm that whether it is a pelvic floor defect or not a pelvic floor defect?
Ma'am, through the day as the patient goes about her day, that mass will increase, and when she's in a dependent position or she's lying down, it will reduce.
Yes.
So that is there in this patient. And
So increase of her symptoms as the day
as the day progresses, yes,
or
ma'am.
with any increased abdominal activity.
Yes, ma'am.
Any activity that increases intra-abdominal pressure, if that leads to aggravation of symptoms of that patient, that means most likely it is a pelvic floor defect. Okay.
Yes, she did not have any urinary or bowel complaints, ma'am. She actually came to, she visited a gynecologist outside in 2019 with complaints of spotting PV. That time she underwent a cervical biopsy and the cervical biopsy was normal.
Okay, so she presented 3 years ago.
Yes,
that
ma'am.
time she was 70 years
Right.
old. And it was again a case of, so it becomes a case of postmenopausal bleeding.
Yes, ma'am.
Okay, so you said that cervical biopsy was done. If you say like this cervical biopsy, I think, was it looking like a cervical cancer?
Cancer, yes, ma'am. Actually, ma'am, when we examined her, there were decubitus ulcers. So she said, in view of ulcers which she had,
Yes.
even then a biopsy was done for her.
So maybe it was not a cervical biopsy because decubitus ulcers
Right.
are not
Not
on the
cervix, right.
They are
Yes,
on
ma'am.
the vagina.
Vaginal
Yes, ma'am.
epithelium.
Okay.
Yes.
So it was not a case of, most probably it was a prolapse, long-standing prolapse, which had led to
contact bleeding. or
which had
something.
led to decubitus
Decubitus
ulcers,
ulcers.
which were actually bleeding.
Yes,
So
ma'am.
biopsy was okay. If a patient comes to you,
Yeah, right.
okay, with postmenopausal bleeding,
Yes, ma'am.
and on examination and mass PV also, and on
Yes,
examination you find there is a one big decubitus ulcer.
Right.
Yes, ma'am.
Will you take biopsy?
There is a decubitus ulcer, and she has come with, ma'am, long-standing history.
70 years, same patient.
Same
if she
patient.
comes to you
Yeah.
with first episode of postmenopausal bleeding, you are concerned, you examine, cervix looks okay, and there is a decubitus ulcer in her vagina.
No, ma'am.
No. We would deposit it
Very
and then
good.
tell her to follow up and see.
Yes. So first episode of bleeding, from when the patient comes to you first, biopsy is not at all required. Okay, you just deposit only in cases of non-healing
Healing
ulcers.
ulcers. Yes. Yes.
If you have deposited, patient has been with estrogen cream, but still it will not completely, maybe it will not heal completely,
Yes,
but
ma'am.
healing changes will happen.
Yes.
If those are happening with 1 week or 2 week of pessary or repositing it into the vagina, then it is good enough. Then
Yes.
the diagnosis of decubitus ulcer is confirmed.
Yes.
But if it is not showing any signs of healing and continuously bleeding, then you must take a biopsy.
Yes.
Okay. So biopsy was taken, and what was the report
Ma'am.
3 years ago?
That was normal. He said there
So it
was,
was a
no
decubitus
sign of
ulcer.
or suspicious of any malignancy.
So, then
She visited us just 2 months back. Ma'am, that time she was given the option of vaginal hysterectomy versus the ring pessary, but she chose to go ahead.
but us means what?
Right.
She
Ma'am, she
visit-
visited a gynecologist from whom she was referred to us, and there she was given the option of vaginal hysterectomy. But then she denied surgery, and she said she wanted to try the insertion of a ring pessary, but after it was inserted 2 days later, the ring pessary was expelled. And then she did not follow up immediately. Then she came to us after 2 months.
Okay. So now again, we'll discuss about the stage of prolapse little later.
Yes.
But can you tell me just, if you give pessary, what could have been the cause of failure? Pessary was a good treatment for repositing of
Right.
this thing, prolapse in her
Yes,
vagina,
ma'am.
so that it heals. Okay.
Yes.
But it fell down, you said,
Yes,
pessary.
ma'am. Yes.
So just we'll learn it little opposite way.
Okay.
So what do you think would have been the reason for falling of this pessary, so that we know that which are the patient whom we should not try
Not-
putting a pessary?
Yes, ma'am.
Yes,
Ma'am,
ma'am.
I think two very common things here would be, one, the size of the pessary probably was not adequate. Secondly, she had a very advanced degree prolapse even
Yes.
at that time.
Right.
Okay. And any other thing which we commonly talk about? So one thing correctly you said, stage 1 and 2,
Yes,
pessary
ma'am.
works well.
Yes, ma'am.
Stage 3 and 4, pessary does not work well.
Right. Yes.
Okay. One more factor, very important, which I have seen, wall prolapse again, pessary, but this was not a case
Not
of
a wall
wall prolapse,
prolapse, yes,
just
ma'am.
enumerating it. There's something in the anatomy which has gone wrong, so that the pessary will not be held properly. Muscle tone.
Oh, ma'am,
Muscle
if
tone,
she
yes.
has a weak muscle tone, then
Yes,
it won't hold the pessary.
If
Yes, ma'am.
introitus is very big anatomically
Yes.
or physiologically, if muscles have lost their
Lost.
tone,
Yes,
it
ma'am.
will
Pessary
not
will
hold.
not hold.
So important thing, when you are every patient, you cannot give an option of pessary, because after 40 years she has
Right.
got the courage to come to a doctor. After that, if you give her a treatment, something which is not going to work,
Yes, ma'am.
patient will lose faith and she will feel more devastated that even treatment is not working. So
Right.
choosing the patient is very important. So advanced stage prolapse,
Yes,
stage
ma'am.
3 or 4, then
Size of pessary.
size of pessary. So when we will decide that
Yes, ma'am.
we have to give.
Right.
So what are the patient factors that we should
Okay.
not offer pessary?
Ma'am,
Yes.
muscle.
Poor
Muscle
muscle
tone.
tone. And
Bigger introitus,
Yes, ma'am.
wall prolapse.
wall prolapse.
These are
Yes.
the common things where usually pessary will have problem in holding the uterus inside. And because what pessary we use is ring
the ring
pessary
pessary.
here.
Yes.
Some obliterative pessary
Yes,
is an
ma'am.
option for these women. And if I remember it well,
Yes, ma'am.
patient said that many years ago when she was staying in a foreign country,
Yeah, it was tried and even that did not work.
Yes, one cube pessary was also tried for
Right,
her,
yes.
Yes,
and which she felt a lot of pressure and pain, and she got it removed.
Yes, ma'am.
Yes, ma'am.
Then
Yes, so then she came to us, ma'am. After the pessary was expelled, 2 months later, which is now 2 weeks back, she had come to us, and we gave her the option of one, either a surgery with vaginal hysterectomy, or because she even initially denied surgery, we gave her the option of an obliterative surgery, that is colpocleisis, for which she readily agreed.
yes, okay. So pessary was not working for her, so the only option left for her was surgery.
Yes, ma'am.
And surgery at 73 years old, as you said correctly, she was not sexually active.
Yes,
she
sorry, ma'am.
was
She
old
also wasn't
patient.
sexually active since the last
And
10 years.
we offered both the methods for her, one reconstructive surgery and
One
one is the
obliterative.
obliterative
Yes,
surgery.
ma'am.
And you said that she was one of those educated patients who understood and knew herself. She opted for
Colpocleisis.
Colpocleisis, yes.
procedure. So now my question to you is, what are the differences?
Yes, ma'am.
For this patient, stage 4 prolapse, we'll come back to the examination
Yes,
again.
ma'am.
But if you choose, what are the advantages when you are counseling the patient of a reconstructive surgery versus a obliterative surgery?
Okay. Ma'am, in a reconstructive surgery, first is that we will be removing the uterus. And so in that case, probably chances of any possible malignancies later on that can be eliminated.
And no, you have to tell what are the, either you tell the advantages of both or disadvantages of
Okay.
both. If you are giving her an option of reconstructive surgery,
Yeah.
okay, what are the disadvantages?
Disadvantages, ma'am, recurrence.
Okay. What are the, while doing recurrence will happen, wall prolapse Success we'll discuss later.
Okay.
At the time of surgery.
Like the complications in a
Complications?
reconstructive surgery are more than
More
an
common.
obliterative surgery.
Why reconstructive surgery has more
It
complications?
is more invasive.
More invasive
Invasive.
in what sense? In simple terms so that everybody understands. Can you explain it?
Ma'am, in the case of a reconstructive surgery, we have to enter both anterior and posterior pouches. We have to open
We are
the cavity.
We are entering the peritoneal
Yeah.
cavity.
Opening the peritoneum
cavity.
Okay,
Yeah.
as soon as peritoneum you open, you are likely to injure all possible
Yes, ma'am.
things: bladder, bowel, ureter,
Hmm.
and maybe you means there is always a risk.
Yes.
Whatever good surgeon you are, how much ever good you are, and whatever, there is always a risk of first injury, bleeding, more time,
Yes,
and
ma'am.
infection into the
Yes.
peritoneal cavity, more so in this age group.
Yes.
Okay, so all these complications are there.
Mhm.
Blood loss is definitely more. When
More,
you're
yes,
opening
yes.
and doing the entire hysterectomy,
Yes, ma'am.
blood loss is more. Okay, then anesthesia,
Yes, ma'am. That has to be
It's
At
a
least
longer-
spinal.
At
yes,
least spinal.
at least spinal,
Yes.
and it has to be longer
Yes, ma'am.
anesthesia. Okay, time taken during surgery
Will
is
be more in a
will be more.
reconstructive
Because
surgery.
reconstructive surgery for this lady, if we are doing,
Yes,
we
ma'am.
are doing hysterectomy,
Yes, ma'am.
we are doing cystocele repair,
Right.
we are doing
Rectocele.
posterior colpoperineopathy,
Yes, ma'am.
and the most important thing
Liver
with
sacral-
fourth degree prolapse,
Yeah.
we have to do some kind of apical suspension.
Yes,
It can
ma'am.
be either utrosacral or it can be
sacrospinous.
sacrospinous. Again, chances of injury, because if you don't do that with this kind of prolapse, it
Definitely
is
recurrence.
Recurrence
it
rate
will
is high. Yes.
it will come back. It will come back as a wall prolapse case. So definitely it is a big procedure, takes more time, does more complication per-operatively, post-operatively. So this is the set of problems. Now, only good thing, if you see theoretically, is that the vaginal length is maintained.
Yes,
Right. Yes.
If you ask me, only one advantage is there, that 73 vaginal length will be maintained.
Yes, ma'am.
Now, compare this with colpocleisis.
Yes, ma'am. It is minimally invasive.
Yes.
The operating time is much lesser.
Much less.
Blood loss is much lesser. It can be done under local or saddle block anesthesia.
Very
Spinal
good.
also can be given. And in this case, ma'am, since we won't be opening any of the peritoneal pouches, those complications can be eliminated. And the vaginal length, like you said, won't be as much. It is not like it is non-existent.
Yes.
It won't be as much as in the case of a reconstructive surgery. Yes, ma'am.
Okay, it depends on your technique, how
Yes,
you are
ma'am.
doing. But it is a sort of obliterative surgery with vaginal length. But
Yes,
then you
ma'am.
have to see, this lady is not active
No, ma'am,
sexually.
she is
Yes.
not.
So definitely the
That is
length
not
of
a criteria
vagina
for
is
her.
not-
Yeah, I mean, not a priority for her.
So whenever you are discussing these options with your patients, it's better to, when if you are giving them a choice to decide. Patient cannot tell you whether this patient was smart enough to be able to
Yes, ma'am.
understand this. However, when you are telling to your patients, it's your duty to tell all the problems, all the advantages and disadvantages to the
Yeah.
patient, so that they can make a
Well
informed
informed
decision
Yes,
for
ma'am.
themselves. Okay. So we started discussing the management part before.
Yes,
Let's
ma'am.
come back to the examination part.
Yes, ma'am. So I'll tell the examination, ma'am. Her general condition was fair. She was a thin-built patient. Her BMI was 21 kgs per meter square. Her vitals were stable. Per abdomen examination, ma'am, it was soft, non-tender, unscarred abdomen. No mass was palpable. When we did the local examination, ma'am, her vaginal walls looked healthy. Cough impulse was present. As far as the defects were concerned, ma'am, anterior and posterior wall defects were less.
So SUI, did you mention?
No, I did
but-
not mention, but we checked for it, ma'am. I was coming to that. There was a grade 3 UV descent, ma'am. Uterovaginal descent was grade 3. Minimal rectocele. Grade 2 cystocele we noted at the time of examination. We tried to reduce it also and look for occult SUI. Demonstrable SUI, ma'am, it was not there. After reduction also no SUI, and she also did not give any complaints. Like we asked, we tried to elicit history, and she was an aware patient, but she did not complain of any urinary complaints.
Specifically in these kind of
Yes, ma'am.
cases, to find out de novo stress urinary incontinence,
Yes.
what will you ask specifically to the patient?
To know whether this patient might present with de novo SUI.
Yes.
Ma'am, when she deposits the mass within
And then
the
coughs?
Oh, no.
No.
Very specific thing, that is one of my favorite, that That is based on natural history of SUI, how SUI happens in prolapse.
In prolapse.
If you don't remember, I'll repeat it.
Okay, ma'am, excessive cough, like.
Or is it after she attains?
No. So what happens in uterovaginal prolapse? It happens in stages. Stage 1, 2, 3, 4.
Yes.
Okay. So when the stage of relaxation occurs, patient will have SUI also.
Okay.
So with stage 1 and 2 prolapse, usually patient will have SUI.
SUI.
But when it becomes 3 and 4,
Yes,
his bladder neck is higher than the prolapsed cystocele, then because of the kinking of this bladder neck,
It's going to be cured.
Patient feels that she is cured. That is the mechanism that once you deposit it back, patient will in post-operative period, she will start having SUI.
Yes.
So the important thing, you have to, when you see these kind of women, you have to ask them that, okay, today you are not having SUI, but try to recollect it 10 years, 20 years earlier.
When the prolapse was lesser. Yes, ma'am.
So this is the important history you have to take.
Ma'am, at that time, probably we did not remember it, but we did ask her if during the course of all this time, if she had any urinary complaints or specific incontinence complaints, and she did not have any. And this time when she had come to us, like she told in the history as well, she had been evaluated 2 months back as well when she was given the option of pessary and this. So she got a pessary put at that time, ma'am, and 2 days later it was expelled, after which she never came to the hospital until 2 months after, because she was still very concerned about the prolapse. And she had trouble walking also because the mass was constantly out. Now when we had examined her this month, it was like next to the cervix, she had these two very identical looking lesions, both equidistant from the cervical os, around maybe half a centimeter or something, and they were both smooth, like the edges were smooth, triangular shaped lesions, which were actually biopsied. The edges were biopsied again, and that also came consistent with cervical tissue. So this time when she
Maybe
had
vaginal tissue.
Yes, vaginal tissue. Vaginal tissue, sorry, not cervical tissue. So then, ma'am, after that we had given her these options. But and as far as the anal sphincter tone was concerned, we had asked her. She did not have any bowel-related complaints, but in the anal sphincter, the tone was good, and sundrain was seen from 2 o'clock to 11 o'clock position, and the perineal body length was nearly 2 centimeters. Yes, ma'am.
What was the genital hiatus? Because you told perineal body,
Yes,
I'll
ma'am.
ask because that's how, suppose this patient would have come to us earlier. Maybe
Yes,
we
ma'am.
also would have thought of pessary.
Yes,
So
ma'am.
how much was the genital hiatus?
Ma'am, her genital hiatus was around
Six
it was a lax perineum,
Yes.
around
Lax
6 centimeters.
perineum.
Yes, ma'am.
Did you try to elicit the levator tone also?
Ma'am, in this patient, levator tone, no, I did not try.
So all these things, maybe we had already made up our mind,
Mind.
as Dheera told management in the history itself.
Yes, ma'am.
Because patient was seen in our hospital, so we had already made up our mind that
Yes,
what
ma'am.
we want to do. But when you are seeing the patient for the first time,
Yes, ma'am. We should
or
have seen.
in your
right.
practice, when you start seeing for the first time, don't believe anybody.
Yes.
So these are important things which will tell you, which will guide you towards the correct management,
Right.
optimal
Yes.
management. So introitus, then perineal body, because we have to see whether we want to repair
Yes,
it or
ma'am.
not.
Yes, ma'am.
Anal sphincter tone, because
Yes, ma'am.
all these things can be tailored
Yeah.
in one
In
sitting.
In
one
one
surgery.
surgery. Yeah, that time we can correct everything.
Yes.
Ma'am, could you tell us once again how to check for the levator tone in the OPD?
Levator tone, you have to put your
Put your
fingers,
fingers,
yes.
Oxford grading, we
Yes,
can,
ma'am.
and tell the patient to squeeze.
Just
You can
squeeze,
keep
okay.
your thumb on the side
Okay,
where we
ma'am.
do levatorplasty
Yes, ma'am. Yes,
outside,
ma'am. Okay.
and then also you can tell. Otherwise, if you are like, even that is a correct way to see it, modified Oxford. You just put your fingers in the introitus
Okay.
and try to tighten.
Ask
Tell
her
her
to
to
tighten them.
tighten the
Okay.
Then based on if it is very good grip, it is grade 5. Okay, if it is
Yes.
lax, means it is 0.
Ma'am, grip meaning like when we place our fingers like that?
Not like this, not like this. Like per vaginal examination you are
Okay,
doing.
okay, okay.
And it's not that though. Levator ani starts from the mid
Yes, ma'am.
part of the pelvis only, but the effect is throughout.
Yes,
Throughout.
ma'am.
Yes,
Understood.
ma'am.
Just
You can
at the
feel it
introitus
like
also
our
you will
fingers
tightening in the grip of
yes,
the.
ma'am.
Okay.
So that you have to see.
Yes, ma'am.
Okay. So all these are important examination finding. I'm discussing it because if, in case of doubt, if you are also thinking that whether should you try a pessary or not,
Yes.
so
This
we'll
is a
repeat
test.
it. Genital height is
Height is-
very important.
Yes, ma'am.
Oxford degree of prolapse or stage of prolapse very
Very
important. Genital hiatus and then the levator tone.
Yes, ma'am.
These things will help you to guide whether you want to give offer
A
offer
trial
a
of
replacement
replacement.
or not.
Yes,
ma'am.
She was not a candidate who
For
would be
pessary
benefited
insertion.
with pessary. So some kind of repair she required,
Yes.
and repair in the form of either reconstructive surgery,
Or
and we have
obliterative.
discussed, and patient opted for an
Obliterative
obliterative
surgery. Yes, ma'am.
So what is the name of this very famous obliterative surgery?
Colpocleisis, Lefort's
Lefort's
colpocleisis.
Colpocleisis. So any one of you, if you would like to explain the steps of Lefort Colpocleisis.
Ma'am, we both will do it.
Okay, yeah. So I'll just begin. Ma'am, initially, first we had filled her bladder to confirm about de novo SUI. After filling the bladder with 200 ml normal saline, gentle suprapubic pressure, or if the patient is under spinal anesthesia, we can ask her to cough. Then we drain the bladder again, catheterize the bladder. We used a sterile marker pen to mark out our areas of dissection. Two rectangular flaps are made on the anterior vagina and on the posterior vagina. Anteriorly, it should be 3 to 4 centimeters below our urethral meatus and 2 centimeters above the cervix. Posteriorly, around 3 centimeters above the posterior fourchette, and again 2 centimeters below the cervix. They should be identical anterior and posteriorly. We give the infiltration with diluted adrenaline, and then we dissect out our the marked areas.
Actually,
The flap.
one or two questions I'll ask
Yes,
so
yes,
that
ma'am.
it becomes clear for you
Clear.
also and for everybody. So when you said that 3 to 4 centimeters,
Yes.
okay, I say it remember as 4 centimeter.
Yes,
4
okay.
centimeter up and 2 centimeter. Easy to remember
Yes,
also.
Yes, ma'am.
And why I am saying 4 centimeters, I always teach in SUI procedure, mid-urethral thing, that urethra is 3 centimeters.
Yes, ma'am.
And we don't want to hamper urethra here.
Right.
Yes.
Okay,
Yes,
we don't
ma'am.
want to occlude. And many of these women require tapes also.
Yes,
mid-urethral.
yes,
So
yes.
we don't want to fiddle with that space. We
Yes.
want to conserve that space.
Yes, ma'am.
Now, if you give the incision at 3 centimeter,
Right.
when you are taking a bite,
Okay.
you might make it 2 centimeters.
Yes,
Okay,
yes,
we go
yes.
higher.
So we
Yes,
compromise
ma'am.
on that
Yes.
space.
So
Yes,
we
ma'am.
just give a margin of 1 centimeter
cent-
extra
yeah,
there.
right.
3 centimeter urethra plus 1 centimeter.
Yes, ma'am.
And easy to remember. Also, that top part,
4
what you will
and
wear,
half.
2.
Yes.
Yes, ma'am.
And behind also
Behind
it is
also
the same.
4
And 2.
two.
Yes, ma'am.
Okay.
Okay,
Yes,
easy
Yes,
to
ma'am.
understand.
Yes, ma'am.
And yes, ma'am. So then we infiltrate with diluted adrenaline.
One more thing,
Yes,
Acha,
ma'am.
I can ask it later also,
Hmm.
or you can tell me now
Yes.
Yes, ma'am.
that when you are planning of colpocleisis,
Right.
if you are planning, if you are thinking that I can do both procedures with same efficacy and whatever is in your mind, who are the best candidates to choose for colpocleisis as far as surgical convenience or surgical results are concerned?
Ma'am, advanced degree prolapse. again.
Advanced degree. Advanced degree prolapse also, I will add one word, complete vaginal eversion.
Yes, yes.
Yes.
Because then
Okay,
only you
yeah.
will be able to approximate
Approximate.
both the flaps.
Yes, ma'am.
Otherwise, going inside and dissecting is not very good.
Hmm.
So the effect also will be nice and anatomically beautiful results also you will
Hers
get.
was a complete
vaginal
eversion.
eversion. So
Yes,
stage
ma'am.
4 prolapses will be
the
always
best.
complete vaginal
Yes,
eversion.
ma'am.
When there is no vagina, when the prolapse comes out, you have no place in the vagina. These are the best people to do.
Yes, ma'am.
Okay, and they will get the best result. They will get
Yeah.
at least some length of the vagina.
Yes, ma'am.
Okay.
Yes.
Like in this case also, we had
Okay.
attained.
So complete vaginal eversion.
Yes,
One
ma'am.
more thing I told you that day in OT. The other thing, when you are choosing your patient for colpocleisis, and you can say that your result is going to be best.
Ma'am, again the levator, no,
Something in the prolapsed mass.
something.
One is the complete vaginal eversion.
Oh, both should be equal. Defects
Anterior.
should be
It's
equal.
anterior and posterior defect.
Defects
Right.
should be equal.
So
Yeah.
cervical os, if it is in examination PPT also, which is uploaded in YouTube, I always tell, we have to see whether the anterior defect is more or posterior defect is more, or both are equal. Both are equal means you will get the cervical os at the center of it.
Yes.
So if the cervical os is at the center, that means anterior defect is equal to the posterior,
Posterior
defect,
defect.
you will get the best
Best
cosmetic results or
Yes,
best
ma'am.
anatomical results. in
This
this
lady
patient.
had more or less the same kind of
Same
defect.
Little more of
Anterior, yes, ma'am. Little more of
but-
anterior, but surgically, like it was.
Okay. Then
Then, ma'am, we dissect out the rectangular flaps and we denude the vagina of the mucosa, the pubocervical fascia below. Once the flaps are denuded, then ma'am, first
So
we
I
start
want you to focus on one more thing.
Yes, ma'am.
Always it is important when we do vaginal hysterectomy and reconstruction also, very important thing, how much vagina you want to remove. Thick or thin?
When we are doing
This now you tell,
ma'am,
because
thin.
every time.
We have to
Thin.
remove thin
Thin.
vagina
Thin,
because
so
we
that
want
more
integrity in
and
the
more,
repair.
more and more tissue you have left
Yes.
for
Draining
a
vagina.
draining
Yes.
vagina. Okay, so you have to thinnest possible layer. We are just denuding it.
Yes,
Yes.
ma'am.
If you see after infiltration, best planes you get when you remove thick vagina, but that should not be okay.
Yes,
ma'am.
Okay, you should try to remove
Preserve
Very
as
thin.
less as possible.
Yes, ma'am.
Slice it off.
Yes, ma'am. After this, like she said, once we've removed both the flaps and we have denuded the vagina, after that, ma'am, first we start to approximate the edges. After that, we will take these stitches from both the cervical lips. When we are doing that, in order to keep two orifices on the sides, we placed an RT. Like we placed a Riles tube in order to ensure patency, and we took about, I think, 3 sutures anterior to posterior of the cervical lips, through the cervical lips. And after that, ma'am, we start taking
It's not through the cervical lips. You have left 2 centimeter margin.
like
So that is
from
the
from
margin,
behind.
so that the cervical os is inverted.
Yes, ma'am,
So
yes.
we are not occluding cervical
Yes,
os.
yes,
Very
yes,
important.
yes. Yes, ma'am.
So we are taking from the edge of the vaginal mucosa from where you have cut, so that it is inverted and still it is a part of the
Patent,
tunnel.
yes.
It is patent.
I think when we put the surgical video, we'll be able to explain better.
Yes.
Yes, but we'll take it from behind and then come out to the posterior lip. So we took about 3 like that, ma'am, and we placed the cervical. We had placed the RT. After we had taken the cervical ones, we took the RT out, and then we started to approximate.
No.
We
You take the RT out at the end.
Okay, at the
Yes.
end.
Okay.
Okay.
So entire, see where you have left the skin. 2 are the edges, 4 centimeter, 4 centimeter.
Yes,
Those
ma'am.
are separate. When you have removed the rectangles, actually you have kept 2 strips of vaginal mucus on the sides also.
Yes.
And this is one strip, 2 centimeter on each side of the cervical os of the cervix. So we are making a tunnel. We are putting interrupted sutures. We are closing it so
Yes,
that
ma'am.
the cervix goes inside,
Yes.
and on both the sides,
sides
also we are.
also.
So when you are closing, you have to take multiple bites, including the pubocervical fascia and the vaginal mucosa.
Yes, ma'am.
And multiple bites on the sides and multiple bites on the center.
Yes.
And put the RT in this tunnel. This
Yes.
this will not. Somebody asked during the surgery, will it approximate?
Yes.
Will it fuse together?
Right.
Will it get adherent?
No.
It will not get adherent because it is not a raw
Raw
surface.
surface.
Yeah.
Okay. But just to ensure of patency of that canal, we
It
put
is
a
good
Riles
to
tube.
put. Yes,
So
ma'am.
when we are putting Riles tube, actually it is in a U shape.
U shape. Yes, ma'am.
Okay, when you keep on inverting the vagina with multiple sutures, then when it goes up, the entire thing goes up, it will
Yeah, the
be
shape of the
And
RT
even
will
inverted
yes,
U
ma'am.
shape.
Yes.
Yes, ma'am.
After that, when you ensure that after that you pull out your
Okay.
Riles tube
Yes,
at
yes,
the
yes.
end of the procedure.
Yes, ma'am. And then we are going to approximate the
Anterior
rest of
and posterior
yes.
of the cervical fascia until you reach the upper edge of the
Upper
mucosa.
edges,
Yes, ma'am.
Then at the end you approximate it
close
the
the
same
wall.
way.
Yes.
You have to close the like you have done fascia a little bit. You have taken mucosa,
Yes.
mucosa and fascia.
Yeah.
And the last bite also you take the same way. I think it will be much more clear.
Clear with the
in
surgery,
surgical
yes.
video rather than explaining this theoretically. But it is a very simple procedure. Gets over very fast. There is not much blood loss. Anesthesia, you can do it under spinal anesthesia.
Sadia block.
So it's a easy, simple, relatively procedure, and results are very good. What is the success rate of
Ma'am, around
colpocleisis?
98 to 100%.
So the recurrence, you don't have to worry about the recurrence as in vaginal hysterectomy. Actually, when you are doing vaginal hysterectomy, you are not doing anything because uterus was not the culprit.
Yeah.
Okay.
It is actually
Yeah.
the
ligaments
pelvic
and
floor,
everything.
yes.
Yeah. So it has much higher success rate as compared to vaginal hysterectomy and reconstructive procedures. And reconstructive procedure, if done without apical support, has no meaning.
Yes.
Yes.
Okay. So it gives. What are the problems? What problems do you anticipate after doing a colpocleisis?
Ma'am, in some patients there may be, firstly we'll talk about the urinary complaints. Some patients may present with retention, and some patients after some time may develop de novo SUI as well.
So de novo SUI,
Yes.
can you prevent?
Yes, ma'am. We can do that. We have to ask the patients, like you said, that whether through the course of their prolapse they had incontinence at any point, and if they did, probably it would be imperative that we place tape at the time of the surgery, a tension-free vagina.
Or I think the best way is to
Yes.
check it in
Check
OP.
it.
Yes, ma'am. Like we
When
did
the
also.
patient is relaxed,
Yes.
you check it.
Yes.
If you have a doubt, you explain to patient even if she is not telling.
Yeah.
That is the simplest way.
Yes, ma'am.
Okay. Some people advocate that every colpocleisis when you do, you must put a tape.
Yes.
No.
But I think that is the cohort
Cause of
which
the-
ultimately leads to
Lands
retention.
lands up in
Yes.
retention.
Avoiding dysfunctions.
Yes, ma'am.
So we have to be very choosy.
Careful.
And at least I feel personally that incontinence to certain extent we can prevent.
Yes, ma'am.
Yes.
Some patients may present with bleeding also, ma'am.
So urinary, you said first you will.
Yes,
Any
ma'am. So
urinary tract
infections, UTIs are common.
yes.
UTI, incontinence, and
Voiding
Retention.
Dysfunction, retention.
Yes, and
Is
retention.
the problem
problem.
because of the changed angle.
Yes.
And something you have put inside which was not there till now, that uterus might, that bulk which you have actually put inside might be
Cause
causing
some-
some edema and some
Inflammation.
inflammation, and that's why patient presents with retention. But retention, this retention is always
Yes, self-limiting.
Yes.
self-limiting
Yes, ma'am.
retention. So what is the treatment? You just
Ma'am,
put the
prolonged
catheter.
catheterization for 2 to 3
2
weeks.
to 3 weeks. That should be enough. After that, patient will be able to
Void on her own.
On her own, yes.
Then any other problem can occur? You
Yes,
were
ma'am.
saying?
Yes, ma'am. Bleeding. Some patients may present with bleeding, and because now this bleeding, it might get collected inside, so that can be a
Yes.
little serious.
So that's why we have made a tunnel.
Tunnel, yes, ma'am.
Okay. So whatever secretion, maybe if it is bleeding or some
Discharge.
which is coming off the uterus, so that is very, very important. If you're retaining the uterus inside, you have to keep the tunnel.
Yes.
Yes.
And other than that, in some cases, usually when we are choosing such a patient, we ensure that there are no chances.
Very, very important
Yes.
message that you have to see
Ensure.
that, because 73 years, so
Yes.
this age group when we are it should not be having some risk or it should not be harboring a malignant lesion
Yes.
inside.
So we
which
should
are
rule
putting
everything
back.
out.
Yes.
Yes.
Thorough evaluation.
Thorough
is a
evaluation
must.
prior to the procedure is important.
Yes.
So,
Ma'am, they may have in passing stools. Some of them. May,
some may present with
the
bowel-related
constipation, bowel
complaints.
disease.
Again, it is a self-resolving
Self-resolving.
problem,
Yes,
and it will be soon. So, how is your patient doing?
she's
She's
doing
doing
fine.
well, ma'am. She's very comfortable and
Yeah.
happy with the procedure.
Okay, so let's summarize. I think we have prolonged this. There are so many other things theoretically we can discuss about it, but maybe for the next
Next
discussion.
class, yes.
Yes.
So some important points.
Yeah.
If two important take-home messages
Yes.
you can give after this class, that will be really good.
Okay. So first one, ma'am, that I want to give is that what are the patients? Firstly, the most important thing is that our management in urogynecology should be extremely patient specific at all points. So if there is a patient who we are giving the option of conservative management, like you said, we need to ensure that this is a patient who will fit the bill for conservative management. So the 4 points that you told us for patients for whom pessary is not a good option, I think we should revise those. I don't know if I'll be able to tell all 4, but let's go. Advanced prolapse, vault prolapse,
Yes.
loose muscle tone is
Poor muscle
not
tone.
poor muscle tone.
And wide genital hiatus.
Yes. And secondly, what was that?
Dheera, you want to try one
yeah.
till she thinks of a
Yeah.
good
Right.
point.
Ma'am, just to reiterate, I think for any surgery, you have to choosing your patient is very important, and to give the patient the option of the surgery as well. Like especially as this patient was very aware, so she wanted to take a decision whether she wants to retain her uterus or not, and we have to choose our patients wisely for this surgery.
For me, if you tell me to understand or summarize this entire story, one very important point which I want to share with everybody. In India, it looks like we feel that we are very good at doing vaginal hysterectomy. Everybody, even general gynecologists, even practitioners who are working at periphery. This is something which comes with our heredity, with our genes. I think everybody feels that we are confident to do vaginal hysterectomies. But as an art, it is okay. But there is a lot of science also. Okay.
Yes.
And it's not that because you can do vaginal hysterectomy,
You should do it.
you should do it.
Right.
Okay. Because you have to choose your patient well. If the patient is has a lot of comorbidities, she is very old, and she has risk factors for anesthesia, she is not sexually active, then colpocleisis is a very
good
good
procedure.
option. It gets over fast. It is much cheaper. You don't have to do anything. The anesthesia is very small. There is no need of blood transfusion because there is hardly any blood loss.
Right.
And it is a procedure which will work for years.
Yes,
yes,
Okay? There is a very good success rate as compared to vaginal hysterectomy. Repair so many sutures you are using, sacrospinous fixation techniques you are using, and obviously there are multiple risk of injury. So I feel colpocleisis is a very good procedure. Maybe in India or in Asian countries, in
Not
US,
as popular.
and maybe it has become a forgotten art.
Yes.
But I think it is the burden is on us to revive the procedure,
ma'am.
but because it is really good and beneficial for the patients. So I want everybody to start doing it
Yes,
for the
ma'am.
selected group of individuals.
Yes.
And we'll soon be posting a video on this procedure. I hope my girls will edit it.
Yes,
Yes,
ma'am.
ma'am.
Soon.
We do that.